Okay, good evening to you all. Welcome back for another free session with regard to your ONG exam. Now, I think the exam date is fixed and the timetable everything is given. Now, are you guys ready for the exam now? Hopefully, yes. Good. All right. Okay. So, purpose of these sessions is to give you all some recap. Already you have this theory knowledge with you all, but I'm just going to recap everything within a short period of time. I think that will be important for you all to when you do the studies. Okay, so don't worry, you all have a basic good theory knowledge, and we have done enough patients so far. Okay, so I think you guys are now very well equipped with the knowledge and everything. This is just to give you some additional support for your exam. Okay, right. So today, Darwani, I'm going to discuss with you all the medical disorders complicating pregnancy. Okay, so I'm going to recap several topics within this short period of time, and basically and mainly my purpose, my target is not to cover. Say, for example, if you take the preeclampsia, I will not be able to cover A to Z preeclampsia theory, but this is mainly for your SBS. Okay, so SBA tricks actually. Just to assist you all how to tackle with these SBS if you get a question from these topics. Okay, so that we will start with preeclampsia. That is one of the very common exam question. Definitely we will get a question from preeclampsia. So we will start with preeclampsia and we will move on. Okay, right. I'll just give a brief introduction about preeclampsia. So what is preeclampsia? What is the definition of preeclampsia? Blood pressure more than 140 over 90. Blood pressure more than 140 over 90. 2 or more occasions. Measures after or detected after 20 weeks of gestation. So for you to diagnose preeclampsia, all these criteria should be there. Blood pressure should be more than 140/90. There should be at least 2 readings, ideally at least 3-4 hours apart. And the blood pressure was normal before, now developing high blood pressure after 20 weeks. This 20 weeks cutoff is very important after 20 weeks. And this blood pressure should settle within 6 weeks postpartum period. Without any treatment, within 6 weeks, it should come back to normal. So someone need to have high blood pressure with all these criteria, plus when there is proteinuria and edema, that is called preeclampsia. Proteinuria. So in addition to all these things, you need to have proteinuria, protein in the urine. So why this 20 weeks business comes? Yes, exactly. So when you are checking the blood pressure in pregnant ladies, you have to check either in the seated position or in the lateral position. That's true, right? So why this 20 weeks business came? Because preeclampsia is a disease or a disorder mainly involved with the placenta, abnormal placenta. Okay, so you all know that can you hear me, Darwani? Yes, good. Right. So this is the mother. Okay, this is the baby on this side. Baby is on this side. Okay, this is the mother's side, and this is the placenta. This is the placenta. This is the maternal side. So before pregnancy, the endometrium contains very high resistant vessels like these, very tiny high resistant vessels. But during pregnancy, because non-pregnant uterus need only very small amount of blood supply, so they have enough. These spiral, these are called spiral arterioles, high resistance, small blood flow, but that is adequate for them. But when you're pregnant, the baby is demanding. Baby need more oxygen, more carbon, need to excrete more carbon dioxide, and they need to get more amino acid, glucose, and everything through the uterine wall or through the endometrium. Okay, so having these high resistant vessels, you can't do that. So you need to convert these high resistant vessels into low resistant dilated vessels like this. Low resistant dilated vessels. This is done by the placenta. So when the placenta is formed, placental cells invade into these blood vessels and cause structural damage and convert them into high resistant vessels into low resistant placental legs. So when you have low resistant like barrels, like tap like structures in the endometrium, so you can do enormous blood supply to the uterus and to the endometrium. So baby can be well nourished. So this happens in two steps, Darone. This formation of these high resistant vessels into low resistant vessels happen in two steps. Or the placenta is formed in two steps that we call first wave of placentation and the second wave of placentation. First wave of placentation happens around 8, 10, 12 weeks. Mainly the latter half of first trimester, you get the first wave of placentation. The second wave of placentation occurs around 16, 17, 18 weeks, like before 20 weeks normally. In preeclamptic patients, the problem is first wave of placenta is okay, but the second wave of placenta is abnormal. That means it doesn't happen, it's not taking place in a proper way. What will be the end result? End result is, now you need to convert these high resistant vessels into low resistant vessels. However, since the second wave is defective, you can't do that conversion. So what will happen? So ultimately, the baby will not get these low resistant vessels. Instead of that, these almost like spiral arterioles will be remaining there. So they have high resistance. So the baby gets only a small blood supply, small amount of oxygen, small amount of nutrients and everything. So what will the mother do? In order to overcome this resistance, mother will increase her pressure. When you increase the pressure, at least you can give some nutrients to the baby, even with these high resistant vessels. That's why the blood pressure rises in the maternal side. Why the blood pressure rises after 20 weeks? Because this should complete by 20 weeks. If this is not happening by 20 weeks, after 20 weeks, what happens is mother's blood supply, blood pressure is rising. So one of the features of preeclampsia is rising maternal blood pressure, more than 140/90. So this is actually protective to the baby. If the mother can't increase the blood pressure, if the mother is not increasing the blood pressure, baby will not get anything. Okay, so that's why in preeclamptic patients, you should not drop the blood pressure suddenly, drastically, because otherwise baby is going to suffer if you drop the blood pressure. So blood pressure is going up, and when the blood pressure is high, when there is high pressure flow, it may damage some of the endothelial structures. Within the blood vessels, you have the endothelium. So endothelium will be damaged because of this high pressure as well as these immunological reactions. So when the endothelium is damaged, endothelium is there everywhere in your body. You have the blood vessels in the brain, so you have endothelium there. Central nervous system, yes. Kidneys, yes. Liver, yes. So everywhere where you have this endothelium, this disease can spread. That's why preeclampsia is a multisystemic disorder. It's not only involved with the kidney, causing proteinuria, but it can damage your liver, it can damage your central nervous system, it can damage your coagulation, liver, and everything, almost everything. So this is a multisystemic disorder. Okay, so this is the basic pathophysiology of preeclampsia. Then, you have to, when you are studying, you have to see what are the risk factors for preeclampsia and all these things you have to see with your theory note. I'm not going into that detail. Okay. So preeclampsia mainly a problem of the defective second wave of placentation. Okay, is that clear, Darwin? Yes. All right. Yes. Second wave of placentation. All right. So we will come to straight away to the management of preeclampsia. Now, what are the complications of preeclampsia? First of all, complications. So when you come to the complications, preeclampsia, you have preeclampsia, and most of the people who are having preeclampsia, they are quite stable. They are not unstable. However, at one point, these preeclamptic patients can go into what is called impending eclampsia. That means they become so unstable. That is called impending eclampsia. Impending eclampsia. Then, soon afterwards, they can go into more dangerous state that is called eclampsia. Okay. Remember, not all preeclamptic patients are unstable. Okay, they are okay, but you have to keep on eye and you have to keep monitoring and keep under surveillance. Okay, so they can, one of the complications is they can go into what's called eclamptic state. Eclampsia means convulsion. When you have convulsions, patient is basically hypoxic. It can damage the mother as well as it can damage the baby. One of the complications of eclampsia is they can develop intracranial hemorrhages, or they can go into acute heart failure. Those are the two reasons why eclamptic patients are dying. So this is MCQ. The commonest reason is acute heart failure. Other thing is they can develop strokes, maybe hemorrhagic strokes, CVA, cerebrovascular accidents. So preeclamptic patients can go into eclamptic state. Why we are worried about eclamptic state is these are the main complications. They can go into acute heart failure and can die, or else they can develop a stroke and die. Not only that, when you develop eclampsia, they can go into multi-organ failure. They have renal failure, liver failure, DIC. So all these complications can happen with eclampsia. But the commonest reason why patients are dying is because of the acute heart failure. MCQ. Acute heart failure. Okay? Right. So I told you one of the complications of preeclampsia is they can go into this eclamptic state. So we basically want to avoid these eclamptic fits. So before they go into eclamptic state, they will show some what are called impending features of eclampsia. Impending signs and symptoms of eclampsia. What are these impending? So-called lakun. So-called lakun. Right? What are these impending features? Start from the top. Headache, maybe the frontal area, headache. Visual disturbances like, blurring of vision, flashes, floaters, double vision, those things. Right? Makeup in level here. Oh, the cup pain or doctor, then you are worried. Okay, double vision, blurring of vision. But we are paying double vision, blurring of vision, flashes and floaters, and all these things are visual disturbances. So headache, visual disturbances. When you come to the mouth, nausea and vomiting. Nausea and vomiting. And when you come down, epigastric pain or right hypochondrial pain. Epigastric pain, right hypochondrial pain. When you go down, reduce urine output. Reflexes, what will happen to the reflexes? Exaggerated reflexes. And not only that, clonus. Clonus, more than 3 beats are clinically very significant. Clonus, you know how to check the clonus in your medicine, right? Clonus more than 3 beats like this. If you get 3 beats of clonus, that is highly significant of impending eclampsia. Exaggerated reflex with clonus. So those are called impending symptoms of eclampsia. Impending symptoms of eclampsia. So that is kind of a severe form of preeclampsia before they go into eclamptic state. Okay, Darwani. So we are discussing about the complications of preeclampsia. One of the complications is eclampsia. So when they develop eclampsia, they can go into acute heart failure, stroke, multi-organ failure. Before a patient going into eclamptic state, they will show some abnormal features. Those are called impending symptoms. Okay. What is the other common just another dangerous complication of preeclampsia? They can go into what is called HELP syndrome. HELP syndrome. Hemolysis, elevated liver enzymes, and low platelets. These are mainly hematological findings or biochemical findings. Okay. There is hemolysis, hemoglobin level is dropping, and the hemolysis indicators like LDH and all these things will be rising, evidence of hemolysis. Platelet count will be dropping, that is very important, dropping platelet count. And liver enzymes may be rising, like SGPT, SGOT levels will be rising. So if a preeclamptic patient having those features, also biochemical features, then you call, it's not preeclampsia, it is now HELP syndrome. HELP syndrome. It's also a severe variant of preeclampsia. Okay, right. When it comes to the management, Darwani, when it comes to the management, now we know where's the problem in preeclampsia? Placenta. Placenta is not doing their job properly. Where's the problem in Sri Lanka? Parliament, politicians. They are not doing their job properly. That's why we are suffering, isn't it? So here, so what should be the solution? You have to remove all these 225 people and then put new people, hopefully, something like that. So here, preeclampsia, we know the problem is at the level of placenta. What we have to do? What is the treatment? You have to take the placenta out. How you can take the placenta out? Yes, you have to go for a delivery. Delivery is the only treatment for preeclampsia, nothing else. There is no other drug which can cure placenta. Preeclampsia. It's the delivery. Okay, right. So having that thing in knowledge, so we'll come to this clinical scenarios. We know the management of preeclampsia is delivery. However, if a patient who is having preeclamptic symptoms and also impending symptoms, we know next step is they can develop eclamptic fever. A patient who is having preeclampsia and impending symptoms, next step is they can go into eclamptic fever. So, what is the management? Management is delivery. However, when you are going for a delivery, Dargo, if a patient is having impending symptoms, at the time of delivery also, or while you are waiting for the delivery also, patient can go into eclamptic state. So you have to temporarily stop this disease process. How you can temporarily stop a preeclamptic patient going into eclamptic state? That is by giving Maxalfate. Maxalfate will temporarily prevent a preeclamptic patient crossing into eclamptic state. However, that is not a definitive treatment for preeclampsia. Definitive treatment is delivery. Okay, right? Right. Okay, now we will discuss several clinical scenarios and how you can, these are the possible clinical scenarios as far as your SPAs are concerned with regard to this topic. Okay, now in preeclampsia, or in any obstetric emergency, your priority should be given to the mother, not to the baby. Okay, Charita, and you give your priority to the class. Alright, so priority in obstetric always given to the mother, always mother first. We don't worry about the baby initially, you consider the maternal well-being first. Okay, right. So we will consider these scenarios. First scenario is say 28 weeks of 20 weeks is 20 weeks of pregnancy, 28 weeks of pregnancy. Suppose blood pressure is 170 over 100 and albumin 2 classes. She's complaining of a headache. She's complaining of a headache. So what is this condition? Suppose patient was initially normal, her booking blood pressure was normal, she's now 28 weeks, priming, blood pressure is very high, 170 over 100, urine albumin 2 classes, and she's complaining of headache. What is this condition? This is impending eclampsia. Very good. This is not pure and simple preeclampsia. This is impending eclampsia. Why you said it is impending eclampsia? Because she is complaining of a headache also. High blood pressure, urine albumin 2 classes. Definitely, you know this is preeclampsia. Not only that, she is having impending symptoms. Okay. How are you going to manage this patient? She is just 28 weeks. So, what about the situation of the baby? Is the baby well grown? Or is the baby grown adequately? No. 28 weeks means it's a preterm baby, isn't it? So, preterm baby. So, if you deliver at 28 weeks, so pediatric you can't make them survive at 28 weeks. It's extremely difficult, especially in Sri Lankan setup. So, will you go for a delivery at this situation, or will you try to control the blood pressure, stabilize the patient and continue the pregnancy till the baby achieves maturity? So, this is one of the common scenarios that you will come across in the exam. Mother looks quite unstable, however, extremely preterm. So, this is preeclampsia, you must deliver the baby. My problem is, are you going to deliver now or are you going to wait some more time? What should be your answer? I told you beginning, Darwani, right? In obstetric, main concern goes to the mother. Is this mother stable? No, not at all. Why do you say she is not stable? Not because of preeclampsia. She is having impending eclampsia. So she is quite unstable. Means if you are not going to treat this patient, she is going to throw a fit and she can die. So mother is at risk at this moment. Okay, mother is at risk. So what is the definitive management? Definitive management is delivery. Don't think about the baby, you have to go for a delivery. Okay. Delivery can be vaginal delivery, can be cesarean section. However, if a 28-week primary usually is not open, unfavorable service, most likely they will end up in a cesarean section. But anyway, vaginal delivery is not contraindicated to preeclampsia. Remember. Okay. So anyway, we know definitive management is delivery. But is she stable for delivery? No. Pulasti, she is not yet stable for delivery. Why you say she is not stable? Because she is having impending symptoms and her blood pressure is high. So, how you can make her stable? So, you have to make her stable by starting maxsulfate. Maxsulfate. You start maxsulfate. What is the dose? 4 grams followed by 1 gram per hour infusion. So you start maxsulfate, and with the maxsulfate, the risk of eclampsia will be minimized. You can't 100% remove the risk of eclampsia, even with sulfate. Still, some patients rare can develop eclamptic fit, but the chance is very low. So what you do though, first of all, the drug of choice is sulfate. Start sulfate and stabilize the patient. Once you start sulfate, normally within 24 hours, you have to consider the delivery. You have to arrange the delivery. So your first step is you start sulfate, and within 24 hours, you have to arrange the delivery. Within 24 hours, arrange the delivery. Okay? Right. So, with regard to sulfate, you start sulfate before delivery. You have to continue sulfate throughout the delivery, and you have to continue sulfate even after the delivery, at least up to about 24 hours. So, when you start sulfate, you have to deliver within 24 hours. During the delivery, or the cesarean or normal delivery, you have to continue sulfate. After delivery also, you have to continue sulfate at least for 24 hours. Okay, remember. So your first option or the next step of your management would be sulfate. So sulfate also the calcium channel blocker. So it might control the blood pressure. However, if the blood pressure is still high, what are your next options to control the blood pressure? You have nifedipine, you can use nifedipine, labetalol, hydrolysine. These are the other emergency drugs that you can use to control the blood pressure. Nifedipine, labetalol, hydrolysine. These drugs can be used in addition to sulfate to control the blood pressure. However, now you all know, I told you at the beginning, in preeclamptic patients, the baby survives because of the maternal high blood pressure. If you drop the maternal blood pressure drastically, that is not going to be beneficial to the baby, because the baby is getting the oxygen supply because of the high pressure given by the mother. So, preeclamptic patients, you have to drop the blood pressure, not suddenly, but gradually, stepwise manner, you have to drop the blood pressure. So you can start nifedipine, you can start labetalol, you can start hydrolysine. Remember, hydrolysine, one of the problems is, mainly with the hydrolysine, it may drop the blood pressure drastically. So unless the blood pressure is extremely high, you don't normally start hydrolysine. Labetalol is a good option, and nifedipine also you can use. Hydrolysine, remember, if the blood pressure is extremely high, then yes, hydrolysine you can consider, but problem with hydrolysine is it may drop the blood pressure suddenly. So you start sulfate, stabilize the patient, control the blood pressure, and then go for a delivery. Don't think about the baby who is extremely preterm at 28 weeks. So you can just give dexamethasone to give some support for the lung development of the baby. But again, dexamethasone, you all know that it's not a fast-acting drug. It takes at least 48 hours for the full action to come into play. However, at least to get some action, better to give dexamethasone. So this scenario is mother is having severe preeclampsia or impending eclampsia, baby is preterm. Do you think about the baby first? No. Only concern goes to the mother, stabilize the mother with sulfate and go for a delivery. So in preeclampsia, if the mother is methyl dopa is not an option at all in this emergency situation, because methyl dopa action comes in about 48 hours later. If you start methyl dopa today for a preeclamptic patient, by the time the action comes, patient will be 6 feet down. It's a slow acting drug. Okay, so methyl dopa is not an option in case of hypertensive emergency. Okay, those are the 3 drugs that you can use. So I'm telling you again, right? Preeclampsia patient, if the mother is unstable, go for a delivery after stabilizing. So in the patient, if they ask, what is your next step? So what you have to do there? See the scenario. Is this mother is stable or unstable? If the mother is unstable, don't think about the baby, go for a delivery. So your next step would be max sulfate, but your best step would be delivery. Okay, so wait the patient come. So we have discussed a case where mother is unstable. The second scenario, suppose, again, we will say 28 weeks, right? She's 28 weeks, first pregnancy, having blood pressure of 150 over 90. Urine albumin 1 plus. No impending features. No impending features. What will you do? Suppose previously she was a normotensive patient, first pregnancy, and now she is 28 weeks. Blood pressure is more than 140, 150, 90, over 140, 90. Suppose they have measured two times, both times, blood pressure is high. Albumin 1 plus. But no impending features. What is your diagnosis now? What is your diagnosis, Daru? Your diagnosis is, this is again, preeclampsia. However, this is not severe preeclampsia or impending eclampsia. This is pure and simple preeclampsia. Is it dangerous? Preeclampsia, is it dangerous? Yes, yes. Preeclampsia is anyway a dangerous condition. Well, this is dangerous, right? Now, what is the next thing that you have to consider? See whether, now we know that this mother is having preeclampsia, but see whether she is clinically stable or unstable. Is this mother stable or unstable? Now, first of all, forget about that thing. Now, tell me, this is preeclampsia. So, what is your management? This is preeclampsia. What is your management? Management is delivery. Again, I told you all, management is delivery. Preeclampsia. So, management is delivery. Okay. Now, the decision you have to make, am I going to deliver this baby now, 28 weeks, or can I continue this pregnancy for some more time? How you can come to that decision? See whether, how is the mother? Is she clinically unstable or is she clinically stable? But at the moment, this mother is clinically stable. Why you say clinically stable? Blood pressure is not that high, and not only that, she doesn't have any impending symptoms of preeclampsia. So mother is stable. Mother is okay, right? At the moment, she is stable. Then, if the mother is stable, then look at the baby. How is the baby? Do a proper growth scan, see the lipo, Doppler, and everything, and how is the baby. If the baby is not having severe IUTR, reverse intestinal co-error, anything, you can assume baby is stable. So mother is having preeclampsia, mother is stable, baby also stable, not having any severe IUTR or anything. So what you can do? You know, this is preeclampsia, management is you have to deliver. Will you deliver this patient now or will you deliver this patient later? Or how long you can drag this pregnancy? Yes, Anisha. How long you can drag this pregnancy?
Until the baby is mature.
All right. So, Darwani, now in this case, this is also preeclampsia. Mother is stable, baby is stable. So, if the baby and the mother is stable, Since this still preterm 28 weeks, you are not in a hurry to deliver this baby now. So you have to admit this ideally, you have to admit this patient, you have to keep her in the ward, and you have to control the blood pressure, and you can continue the pregnancy while closely monitoring the mother as well as the baby. So you admit the patient, control her blood pressure, continue continuous monitoring. You have to check the blood pressure, you have to check the urine albumin, you have to check the biochemical markers, everything you monitor and try to continue the pregnancy. Meantime, you have to monitor the baby as well. Baby needs serial growth scan, LIPA, Doppler, and everything, and assess, and you have to continue the pregnancy. Now, suppose, since the mother is stable, since the baby is stable, you take a decision to continue this pregnancy. Okay, so what are the drugs that you can use to control her blood pressure? Blood pressure is not very high, so you have options like, again, you can use the nifedipine, labetalol, or else methyldopa also you can use in these kind of patients, because this is not an emergency situation. Nifedipine, labetalol, methyldopa, anything you can use. But the current practice, the first line management is usually labetalol. First line is usually labetalol. Okay, so you start the drug and blood pressure is now under control, mother is stable, she is not worsening, and the baby is stable. So how long you can continue this pregnancy? Pregnancy can be continued maximally up to 37 weeks. So you can go up to 37 weeks. And all preeclampsia patients should be delivered by 37 weeks. You don't drag this pregnancy beyond 37 weeks if this is preeclampsia. So by the time when the baby reaches 37 weeks, you are certain that this baby is now fit enough to come out. So you can safely deliver the baby at 37 weeks. Does this patient need max sulfate? Does this patient need max sulfate? No, no. She doesn't need max sulfate. Why she doesn't need max sulfate? I told you, max sulfate you start to prevent a patient who is an impending symptoms to go into eclamptic state. But this patient, since she doesn't have any impending symptoms, you don't need to start max sulfate. So no need of max sulfate if patient doesn't have impending symptoms. So two scenarios we discussed. First scenario is, First scenario is that patient is having severe preeclampsia, impending eclampsia. So irrespective of the maturity of the baby, you consider delivery after giving max sulfate. Second scenario, patient having preeclampsia, however, she is stable. Baby is stable. So what you need to do? You control the blood pressure and continue the pregnancy as long as you can go, but maximally up to 37 weeks. Maximally up to 37 weeks, and then you have to deliver. If the patient, if a patient doesn't have impending symptoms, you don't need to start max sulfate. Okay. So, what are the indications to start max sulfate? One is if a patient is having impending symptoms, you need to start max sulfate. If a patient develops eclamptic fit, patient is fitting now. Laboratory mass exam, fitting now, fitting, right? So what is the treatment? Max sulfate. Primary prevention as a treatment. And now suppose patient had a fit, eclamptic fit, and she recovered. Still, you need to have max sulfate for the secondary prevention of recurrent fits. Those are the indications to start max sulfate. So this particular patient doesn't need max sulfate. Suppose that the same patient, 28-weeker, having mild preeclampsia, you admit the patient and you assess the mother. Mother is stable. Mother okay. And you assess the baby. Baby is okay. So what is your plan? Nusrat, what is your plan, Daru? You try to continue this pregnancy till the baby gets the maturity. Can you all please switch on your cameras, Daruni? Just show off your faces, right? Lovely faces, right? Right. Okay, right? So, are you okay? Any ghost here? No, right. So, mother is having preeclampsia, so you know the management is delivery. However, she is stable. Baby is stable. So, your management is to continue this pregnancy up to 37 weeks if possible and deliver. Suppose Uma, this patient, now 28 weeks are now you are continuing the pregnancy. Near 30 weeks or 30 weeks, her blood pressure went up, albumin 3 classes, and she complained of vomiting and headache. What is now? What is the condition now? Initially, she had mild preeclampsia. Now she is having impending eclampsia. Okay. Initially, your plan was, your target was to go up to 37 weeks, but now still 30 weeks. Now she has developed impending symptoms and she is now unstable. She is quite unstable because blood pressure is high, albumin 3 pluses, and she's having vomiting and headache. So what will you do, Sandhunika? What will you do? What will you do now, Daru? What is the next step? Now, is this mother stable or unstable? Unstable. Is the baby is mature or not? No, she's not. Baby is not yet mature because still 30 weeks. Okay, but we don't consider the baby. Always you consider the mother. Mother first. Okay. Since the mother is unstable, you have to make her stable. How? Start max sulfate. Make her stable and then go for the delivery. Don't think about the baby. You start max sulfate as before, and within 24 hours, you plan out the delivery. Okay. So, have you all understood, Darwani? Just because a patient is having preeclampsia, you don't have to give max sulfate. Max sulfate should be given if the mother is having impending symptoms. A patient who was initially not having impending symptoms, but later she can develop impending symptoms. So then and there, you have to start max sulfate, stabilize her, and go for delivery. Is that clear? Is that clear, Daru? Right? So, preeclampsia, these are the scenarios that you can come across. The last scenario is, suppose 28-weeker, mother's blood pressure is 150 over 90, albumin 1 plus, right? No impending symptoms. So, how about the condition of the mother? Mother is quite stable. Then what you have to assess? The baby. So when you assess the baby, suppose baby is having severe IUGR, reverse end-diastolic flow. So mom is stable, however, baby is, what about the condition of the baby? Baby is unstable. Having severe IUGR, you know, when you have preeclampsia, baby can get IUGR. It's very common. So suppose baby is having severe IUGR and reversed end-diastolic. What will you do? Anisha, what will you do?
The delivery.
Now, today, it's 10:30, right now, or tomorrow, day after tomorrow, or after a few days. When will you deliver?
It is severe IUGR, so it's immediate delivery.
No, no, no. So when you have a severe IUGR, like Absent or reverse end-diastolic flow before 32 weeks, what will you do? Do ductus venosus Doppler. Do ductus venosus Doppler. Can't you remember? Do ductus venosus Doppler. If ductus venosus Doppler is normal, you have some time to practice pregnancy. Maximally, you can go up to 32 weeks and deliver. If the ductus venosus Doppler also abnormal, straight away you have to consider urgent delivery. So preeclampsia can be combined with IUGR in your patient's study. All right, clear. Vilangida, Zamira, Vilangida. Okay, right. So Darwani, you can get several scenarios. These are the possible scenarios as far as the preeclampsia is concerned for your SPS. One scenario is straight away they will give evidences or clues saying that mother is unstable. So always think about the mother. Always pay concentration on the mother's well-being. Always in obstetrics, first concern goes to the mom. So whatever the gestation, whatever the maturity of the baby, see how is the mother. If the mother is unstable, in the sense, mother is having impending symptoms and severe preeclampsia. So what is your management? Emergency delivery. Before you deliver, start max sulfate, stabilize her and go for delivery. Okay? If the mother is stable, look at the baby. Baby also stable, mother also stable. So what's your management? You continue the pregnancy till the baby achieves maturity. Maximally, you can go up to 37 weeks. Okay, maximally you can go up to 37. So you control the blood pressure, monitor the mother and the baby, and continue this pregnancy up to 37 weeks and deliver. Meantime, if the mother becomes unstable, you start max sulfate urgently as before you consider delivery. Suppose mother is having preeclampsia, mother is stable, baby, however, highly unstable. Severe IUGR with reverse or absent end-diastolic flow. If it is below 32 weeks, you have to consider ductus venosus Doppler. If it is after 32 weeks, what Doppler? Middle cerebral artery Doppler, up to about 34, 35 weeks. Okay? And consider if they are abnormal, go for emergency delivery. If they are normal, especially ductus venosus Doppler is normal, you can go maximally up to 32 weeks. You don't go beyond 32 weeks. Is that clear, Darwin? These are the possible areas where you can get questions. Okay, right? So if you know this stuff, definitely any preeclamptic the SBA that you are going to come across in the exam is not going to be a big issue. So put this theory part solidly in your brain. I know you may be having that thing, but maybe shape a bit, but put everything in an orderly manner. Okay, so shall we move on to the next topic, Darwani? Any question regarding what I have told you all? Then may punchi lamai by vela the next sample. Oh, are you all excited? Looks like you guys are excited and waiting for the exam. All right, okay. Any questions, Darwani, so far? Anything? No. Shall we move on to the next topic? Right? Oh, yes.
So if there's a question like the mother is 35 weeks of gestation and the blood pressure is very high.
The first part not clear, Darwo.
The mother is 35 weeks of gestation and the blood pressure is very high, 170 over diastolic 120. And the question is saying that she's having headache and all the symptoms.
Yeah.
And the question is, what is the next appropriate management? And the answers are IV magsulfate, IV hydrolysine, and then emergency LSCS, oral nifedipine, and then induction with prostaglandins. So in
Yes.
this question, do we select IV magsulfate?
Yes, you tell me the answer, Daru. So 28 week, according to your history, having very high blood pressure with all impending symptoms. So what is the immediate threat for this patient? Immediate threat is she can throw on a fit and die. So your first target is to stop the occurrence of a fit or going into eclamptic state. What is the drug of choice? Maxsulfate. Start maxsulfate. If it is available, start maxsulfate as soon as possible. Then patients, the risk of eclampsia will be minimized. Maxsulfate itself will control the blood pressure. However, if the blood pressure is still high, simultaneously you can start some antihypertensives like labetalol, nifedipine, or hydrolysine. But the main concern is to prevent eclampsia. So, drug of choice. Next step would be maxsulfate. Okay, Daru? Is that okay? Is that clear? Priyanjay, is that okay, Daru? All right, good. Right. So shall we move on to the next topic, Daruni? Good that you asked those questions, right? Now, guys, if you all have any questions, Daruni, please send me. Yes, Daru. Yes.
So in that question, so if the blood pressure is 170 over 120, mean arterial pressure is more than 125. So the ICH risk is higher, right? So it is the most severe one. So we have to, isn't it better to use the antihypertensive first and then give maxsulfate, because the ICH risk is the most, the severe one.
Yes, that's good, right? I agree with you. When the mean arterial blood pressure is more than 125 or 130, there's risk of ICH. But most of the patients, even though the blood pressure is high, you would have seen sometimes patients like the blood pressure is extremely high. There are RGs and CRs at home. They are having extremely high blood pressure chronically, but that doesn't cause ICHs. But here the main problem is that not the. I agree with you all. The blood pressure is high, so blood pressure itself can stop. But more than that, if a patient develops an eclampsia, it's more severe than developing a stroke, because eclampsia means it's a multisystemic disorder. Your next step is always to minimize that risk of eclampsia. Okay, but in practical situation, you start everything together. Like if the maxsulfate is there, you start the maxsulfate. In meantime, if the blood pressure is not controlled, you go for the other second line drugs also. But next step would be always maxsulfate, because you need to stabilize the patient first. Okay, and maxsulfate, remember, itself is a calcium channel blocker, NMDA type calcium channel blocker. So it itself will lower the blood pressure. But however, if the blood pressure is cannot be controlled with maxsulfate alone, you have to consider other drugs. But always, if a patient is having in impending state, if the patient is quite unstable, drug of choice would be maxsulfate. Okay. Is that clear, Daru? But in practical situations, usually you start maxsulfate and same time you are getting ready with other drugs as well. But to exam point of view, the best next step would be maxsulfate. Any other questions? Okay. So shall we move on to the next topic? That is diabetes in pregnancy. Okay. So when it comes to the diabetes in pregnancy, you all know that there are two main types of diabetes that you will come across in pregnancy. That is gestational diabetes. Other one is long-standing or chronic diabetes. Chronic or long-standing diabetes. So long-standing diabetes, you all know. What is gestational diabetes? Gestational. That means pregnancy, something pregnancy specific. Again, this gestational diabetes also appears after 20 weeks. Why? Why do you get gestational diabetes after 20 weeks? Because, what is the reason? The reason is, this is the mother, right? So you have the mother here. So mother through the placenta has to give all the glucose to the baby. So to have enough glucose to the baby, if the mother is having a very tight control of blood sugar, she can't give glucose to the baby because she is having a tight control. So what happens is, when the placenta is developing, they produce various hormone substances. They go into the maternal circulation and impairs maternal glucose homeostasis. That means these hormones, they go to the maternal circulation and increase the blood sugar levels of the mother. They are anti-insulin hormones. What are those hormones, Taruni? HPL, human placental lactogen, cortisol, and all these hormones, they go into the maternal circulation and increase the blood sugar levels. So when you increase the blood sugar level in the maternal side, mother can give adequate supply to the baby. However, if they increase the maternal blood sugar levels more than necessary, then the mother will fall into the diabetic level. Okay, so most of the mothers, they can tolerate this inhibition given by these hormones. However, if the mother is already predisposed to diabetes, like obese one, polycystic ovaries, family history of diabetes, those mothers, they are anyway predisposed to diabetes. So when you get these additional hormones coming from the placenta, their blood sugar will be going very high. So they will be fallen into the diabetic category. That is called gestational diabetes. This is also happens because of the placental excessive hormone production. Okay, so why disease happens usually after 20 weeks gestational diabetes? Because after 20 weeks, placenta is well formed and placenta is big. So this is the time they are producing more and more hormones. So more hormones means you are more predisposed to gestational diabetes. That's why GDL appears after 20 weeks usually, because you have a large placenta. What is the reason why twin mothers and triplet mothers are having high risk of diabetes? They have a large placenta or two placentas, more hormones, more risk of diabetes. So basic difference between gestational diabetes and chronic diabetes is people with chronic diabetes, when they conceive, from the first day of conception up to the delivery and afterwards also, they are having diabetes. So chronic diabetic patient, from the first day 1 of their pregnancy up to throughout the pregnancy, they have high blood sugar levels. Whereas Tamali, gestational diabetes, sometimes your mind may go away from the classroom. Sometimes you may be thinking about your future exams and future internships, sometimes future boyfriends, sometimes girlfriends. Right? So leave them for a time being and think about chronic diabetes and gestational diabetes. In gestational diabetes, what happens? From the first day of their pregnancy, they don't have diabetes, but diabetes happens after about 20 weeks. From 20 weeks onwards, they get the diabetic status. So first part of their pregnancy, they are diabetic free. Remember, this is important to understand. So what is the importance of that? You know, Daro, when it comes to first trimester complications like miscarriages, congenital abnormalities, all these things, complications can happen with chronic diabetics. Why? they have this problem from the first day of conception. From the first day of conception, the blood sugar levels are high. They have microvascular and microvascular complications, so baby can be affected from the day one. So that's why chronic diabetes can cause miscarriages. Chronic diabetes can cause congenital abnormalities. What about gestational diabetes? Gestational diabetes, the problem comes after about 20 weeks. So by till 20 weeks, they don't have any problem. That means miscarriages are more common during this time. So gestational diabetes will not cause any miscarriages. Why? They are appearing after 20 weeks. So as an MCQ, gestational diabetes does not increase the risk of miscarriages. And the other thing is, gestational diabetes will not cause congenital abnormalities. Why? By the time of 20 weeks, all the organs and the systems are developed. So congenital abnormalities you won't see with gestational diabetes. So remember about few differences between gestational diabetes and chronic diabetes. Okay, Chiranjeev, right? Understood? Right, good. Okay, so gestational diabetes is a pregnancy specific condition. Again, placenta is the problem. So once you take the placenta out, that is after the delivery, gestational diabetes, they will go back to normal state. Whereas chronic diabetes, it has been there before the pregnancy also. So they will have more complications. Why? From the first day of pregnancy, they have high blood sugar levels. So they are having high chance of miscarriages, congenital abnormalities like sacral agenesis, neural tube defects. All these problems will be there with chronic diabetes. Management for gestational diabetes is delivery. Once you take the placenta out, the blood sugar levels will drastically come back to normal. Okay. So having said that, when it comes to management, of course, there is no much difference whether you have a chronic diabetes or whether you have gestational diabetes. No much of difference. Okay. Right. So when it comes to management of diabetes, you have three options. That is medical nutrition therapy, oral hypoglycemia, that is named metformin. Third line is insulin. Medical nutrition therapy, metformin, and insulin. What is medical nutrition therapy? Medical nutrition therapy. What is medical nutrition therapy? Diet control. Just diet control. You know, all diabetic patients should control their diet. That is what is meant by medical nutrition therapy. Metformin, you all know, insulin, you all know. Right? Okay, right. Now suppose all the patients, all the Asian patients and Sri Lankan patients, right? We are genetically predisposed to diabetes. So all pregnant mothers should be screened for diabetes during pregnancy. Suppose there is a newly married couple, newly married lovely lady, right? She's now pregnant for the first time. Okay. So I think because she's now pregnant, everybody caring about her, right? Everybody is coming to the clinic. So when a patient comes to the clinic, you are supposed to screen for diabetes for this patient. Okay. So you can do OGCT test as a screening test, or else you can straight away go for a OGTT test. Suppose you are doing oral glucose tolerance test, OGTT test for this patient. Okay. So OGTT test, there are various cutoff values. You don't have to actually remember, but the fasting is T92. So first our value is 180. Second our blood sugar level should be 140 below. Below 140, below like. Roughly these are the cutoff values for OGTT. Suppose this patient is having all three values above cutoff. So what is your diagnosis? She's just at the first trimester, say 10 weeks. 10 weeks of pregnancy, OGTT values are high. What is this condition? Looks like she's having long-standing diabetes or chronic diabetes, which was not diagnosed before. This may be the first time you are diagnosing the condition. Agree or not agree? This is unlike the GDM because GDM usually happens after 20 days. So it looks like chronic diabetes. Okay. Now, how are you going to manage this patient? You have three options: medical nutrition therapy, metformin, insulin. Your OGTT values are high. How are you going to manage this patient? What is your next step of management? I will give some values, right? Now the fasting value is 110, first hour value is 220, second hour value is 170. So she is pretty diabetic. Even one value above the cutoff you consider as diabetes in pregnancy. Okay, what is your next step of management? What will you do? What will you do? What will you do? Next step, next step. You have three options to manage this patient, Charita. What will you do next? Exactly, but not exactly, but you are somewhere there thinking. What you have to do? So this is after giving glucose, but actually we don't know what is the normal diet. How's the blood sugar during the morning time, noon, and evening? How's the blood sugar levels? We don't know. So ideally, Darvo, if you get a high OGTT value, better to do. You can even start one of these options, but the best thing is you can start doing BSS, blood sugar series. You can admit the patient, or you can ask the patient to get it done and come to your clinic. You can do the fasting blood sugar before breakfast, after breakfast, before lunch, after lunch, before dinner, after dinner. So fasting blood sugar. Take the breakfast, lunch, and dinner before and after, like that. So you can get 7 values. Do a BSS. When you do a BSS, Darwani, you can get an idea about the blood sugar. How is the blood sugar of this patient throughout the day? Okay. If the blood sugar is marginally high, say, suppose you are expecting 120, cutoff of 120, but this patient is 125, 130, something like that. Not very high, but marginally high blood sugar levels throughout the day. What you can do? You can put her on the diet therapy, medical nutrition therapy. Give her, yes. Okay, educate the patient regarding the diet. Ideally, this should be done by the dietitian, but at least you also can do that. Okay, give some advices how to control the diet. Then, what you can do is, with the diet control, discharge the patient. Ask the patient to come back in 2 weeks' time. Okay, in 2 weeks' time, ask the patient to come back. You check the blood sugar again after 2 weeks. If the blood sugar is under control with the diet, what you can tell the patient? You can put a label here, good girl, your control is good. So you can tell the patient, look, you have a good control with the diet. You don't need anything else, but keep continuing your diet therapy. That is after 2 weeks. Okay. Suppose after 2 weeks, blood sugar levels are even higher than before or not controlled. What you can do? If it is mildly high, again, you can add diet plus metformin. Or if it is severely high, like 200, 170, 180, 200, like very high blood sugar levels, then you can straight away go for insulin. So if you start metformin, suppose with the diet and metformin, you discharge the patient, get her down in 2 weeks' time, do a BSS. If the control is good, continue the same. If the control is not good, you can increase the metformin dose. Again, 2 weeks' time, BSS, and you can add insulin. And you can adjust the dose of insulin every 2 weekly depending on the control. So newly diagnosed diabetic patients admit and do a BSS. Depending on the BSS values, you can either put the patient on medical nutrition therapy alone, or MNT plus metformin, or you can straightaway start insulin if the levels are very high. And every 2 weeks, ideally, you have to check the control with the BSS plus 3 and adjust the doses. Okay. This is how you normally control blood sugar levels in diabetic patients. You have 3 options: diet, metformin, insulin. But with the patients we discussed, there are 2 indications to go for insulin straight away rather than putting her on diet or metformin. What are those 2 indications? If the baby is macrosomic, either estimated fetal weight more than 90th centile or the abdominal circumference more than 90th centile. Macrosomic, paddy baby, large baby, paddy you have, that means the control is not good. You have to put straight away on insulin. Insulin is the best. Other thing is, if there is evidence of polyhydramnios, yes, polyhydramnios. If the polyhydramnios is there, that means the control inside is not good. Best thing is put her on insulin. So please remember what those 2 indications where you need to start insulin. What are those 2 indications, Darwane? Dilki, what are those 2 indications? If the baby is big, macrosomic, or else polyhydramnios, then straight away, in addition to the diet, you can put her on insulin, even at the first step. But otherwise, normally you put the diet, see the control. If the control is not good, you can put metformin. If the control is not good, you can increase the metformin. If the control is not good, you can go for insulin. But there are no hard and fast rules regarding these 3 options. But definitely, if there is evidence of macrosomia or polyhydramnios, best thing is go for insulin. Okay. So when it comes to the delivery, diabetic patients delivery. So before delivery. So have you all understood how to control the blood sugar in a diabetic patients? So newly diagnosed patient, better to do a BSS and have an assessment. And depending on that, you start on either diet, metformin or insulin. And every 2 weeks at least, you have to assess the control and adjust the doses. Okay. What are the complications of diabetes? First, take the chronic diabetes. Maternal complications and fetal complications. What are the maternal complications of chronic diabetes? Long-standing diabetes. In medicine, you all know that anyone who is having anyone who is having diabetes, they can get macrovascular and microvascular complications. What are the macrovessels? What are the microvessels? Macrovascular diseases like cerebrovascular accidents, coronary artery disease, PVD, peripheral vascular disease, PVD. Cerebrovascular accidents, coronary artery disease, PVD. PVD, pelvic, yes. Okay. So what are the microvascular diseases? Retinopathy, nephropathy, dermopathy, diabetic skin disease, dermopathy, neuropathy, gastropathy. All the pathies under the same. Small vessel diseases like retinopathy, nephropathy, dermopathy, neuropathy, gastropathy. What is gastropathy? What are the features of gastropathy? Have you all noticed some people, when they are eating, they get excessive sipping? That may be a feature of gastropathy. Better to check your blood sugar levels. See my medicine knowledge. Wow, what right? Okay, so those are the microvascular complications of diabetes type 1. Okay, so mother with chronic diabetes, she can get all these microvascular and macrovascular complications. As far as the baby is concerned, what are the fifth complications of diabetes type 1? Start from the beginning. From the after the conception, there is a risk of miscarriage, congenital abnormalities. When you come to the second trimester, there is a risk of IUGR. You know, baby can be either macrosomic and polyhydramnios or else even IUGR. Remember again, IUGR happens only with chronic diabetes, not with gestational. So first trimester miscarriages, congenital abnormalities. What is the characteristic congenital abnormality? Anisha, what is the characteristic congenital abnormality of chronic diabetes? Samira, yes, someone. Sacral agenesis. The sacral bone is not developing. Then keep up again, right? Sacral agenesis. All those complications can come. When you come to the second trimester, IUGR, macrosomia, and they are predisposed to preeclampsia also. Remember, they are predisposed to preeclampsia. Then, when you come to the delivery, if they are going for a normal delivery, there is a risk of shoulder dystocia, risk of cesarean section. After delivery also, there is a risk of postpartum hemorrhage. And one of the other complication is intrauterine death. These babies can die inside without any obvious reason. Intrauterine death. All diabetic patients, babies are having risk of IUD. When it comes to chronic diabetes, these are the complications, maternal and fetal. Take a deep breath. Relax 15 seconds. 15 seconds, okay? Boyfriend, girlfriend, message something like that. So you can send a message. All right, take a deep breath and relax yourself. Okay. Okay, guys, now we have discussed what are the possible complications of chronic diabetes for the mother and to the baby. Come to the gestational diabetes. Gestational. GDM. What are the maternal complications, Taruni? Do they get microvascular or macrovascular complications with gestational diabetes? With your medicine knowledge, tell me, do they get microvascular or macrovascular complications? To get these micro or macrovascular complications, diabetes should be there for several years. 3, 4 years, 5 years. So have you not ever seen a pregnancy going up to 5 years? Hardly any. So GDM will not cause micro or macrovascular complications. Those are MCQs that are. Okay. So read your patient carefully. If they are talking about the GDM, no micro or macrovascular complications. Because it's a short lasting disease. It won't cause these vascular changes. Okay. When it comes to fetus, what are the complications of gestational diabetes? Do they cause miscarriages? No. Do they cause congenital abnormalities? No. Do they cause macrosomia and polyhydramnios? Yes. Possible and common. Do they cause IUGR? No. They won't cause IUGR usually. Remember, gestational diabetes normally do not cause macrosomia. IUGR. GDM usually do not cause IUGR. But chronic diabetes, Sambhavika, can cause either IUGR or macrosomic babies. Okay, clear? Other things are like, IUD risk is increasing, increased risk of shoulder dystocia, increased risk of cesarean section, and all these other complications are common. Yes, stillbirth or IUD, both are same, almost same, right? So babies can die inside, either with GDM or either with chronic diabetes. They can die inside. Other complications are common. When it comes to the time of delivery, time of delivery, right? When it comes to the time of delivery, normally chronic diabetic patients, better to deliver by 37 weeks. Most of the cases, almost all the cases that were in chronic diabetic patients, we deliver by 37 weeks. Because going beyond 37 weeks, the risk of IUD and other complications are more. So better to deliver them by 37 weeks. Chronic diabetic patients. Gestational diabetes patients, GDM patients, if they are having a good control and if they are on diet control only, you can go up to 39 to 40 weeks. Provided that their control is good, no complications to the baby, in that case, you can wait till 39, 40 weeks. That is gestational, remember, gestational diabetes with good control and usually diet control people. GDM on metformin, no hard and fast rules though, but you can deliver GDM on metformin around 38 weeks, you have to deliver it. 37 to 38 weeks, better to deliver. GDM on insulin, again, better to consider delivery by 37 weeks. There are no hard and fast rules as such, but these are the norms, kind of norms, okay? Chronic diabetes patients should be delivered by 37 weeks. Gestational diabetes, diet control, you can go up to 40 weeks, 39, 40 weeks, but metformin around 38 weeks, insulin by 37 weeks, you have to consider delivery. Okay, so how you can deliver them, Darwani? Not always cesarean section. Assess the size of the baby, assess the maternal parameters. Then, if the shoulder dystocia risk is less, you can consider vaginal delivery. But if the baby is macrosomic and short mother, macrosomic baby, evidence of cephalopelvic disproportion, so in that case, better to consider cesarean section. After cesarean section, after delivery of cesarean or normal delivery, after delivery, what is their management? Sanjay Gunasekara, what is the management of gestational diabetes after delivery? Suppose there is a patient who is gestationally diabetic, and during pregnancy period, you have started her on insulin. She is on insulin. Gestational diabetes, however, she underwent a cesarean section for the delivery. After delivery, what will you do? Remember, gestational diabetes is a pregnancy-specific condition. Placenta is the reason, like in preeclampsia. So once you take the placenta out, all these diabetic hormones will be dropped, and the blood sugar levels drastically will drop. So management of GDM after delivery means stop all the drugs. If the patient was on metformin, stop it. If the patient was on insulin, stop it. Stop the treatment. Normally, almost all the cases, they will go back to original or the normal glucose levels after delivery, immediately after delivery. And even in marginal cases also, by 6 weeks time, almost all the cases, GDM, they will go back to normal blood sugar levels. So GDM mothers after delivery stop all the treatments. Okay, and 6 weeks time, suppose GDM mother who was on insulin, after delivery you stop insulin and blood sugar was normal, so discharge the patient. In 6 weeks postpartum period, ask her to get done a fasting blood sugar level, at least fasting blood sugar levels, and come and show you the report. Or ask the MOH to review the report after 6 weeks. Fasting blood sugar levels after 6 weeks. Not the OGTT, though, it's fasting blood sugar levels after 6 weeks you check. And if that is normal, annually, better to do OGTTs. Annually OGTTs. Every year, like, because later she can develop diabetes, so annually OGTTs and 6 weeks time fasting blood sugar levels. Okay, Darwo, right? Suppose there is a chronic diabetic patient, chronic diabetes patient, okay? Samadhi, right? Suppose there is a chronic diabetic patient, Darwo, non-diabetic patient who was on metformin before pregnancy and she conceived. During pregnancy, you have add on insulin. Now she is on insulin plus metformin. After delivery, what will you do?
She has to stop insulin and continue the previous metformin.
Exactly. Chronic diabetic patient, you can't stop everything because she's already non-diabetic patient. So what you do is, whatever thing that you have done during pregnancy, you stop. That means if you have increased the metformin dose, you go back to original metformin dose after delivery. Or if you have added insulin, you stop insulin and put her back onto the metformin regime and continue. So chronic diabetic patients after delivery, you put them back into pre-pregnancy regime. Before pregnancy, whatever she was on, to continue the same thing. Is that clear, Darwane? Clear, do? Right. So, yes. So put this management part and these things into your brain, Darwane, right? So you can get questions from chronic diabetes and gestational diabetes, maybe an MCQ, maybe SPA, right? MCQs, they will be considering the differences between GDM and chronic diabetes. So read the question carefully. If they say diabetes in pregnancy, we don't know whether it's GDM or chronic diabetes, so you have to consider everything. But if they specify and say chronic diabetes, or if they specify and say gestational diabetes, then you have to talk about the specific complications. Management-wise, of course, no much of difference. You have 3 options: diet, metformin, insulin. Okay, right? So do you all have time to discuss anemia in pregnancy in about 10-15 minutes? Nidimatai කියලා දන්නවා. මටත් නිදිමතයි. නිදාගමුද කරමුද විනාඩි 10ක් විතර, right? Are you all okay, right? So take a deep breath. Yes, take a deep breath and relax yourself. All right. So quickly, we will revise about anemia in pregnancy. Okay. So when it comes to anemia in pregnancy, Darwo, again, you have to see what are the maternal complications and fetal complications. What is the main maternal complications of anemia? Anemia. What is the main maternal complication, Darwani? Main maternal complication is postpartum hemorrhage. Yes, PPH. If a mother is anemic, there's a risk of PPH. As far as the baby is concerned, what are the fetal complications of anemia? Now you have come to the end. This is your end, right? So just recap these things, right? No need to write down everything. It's there in your handouts. Okay. Yes. Come to the baby, Darwin. when the mother is having anemia, what are the possible fetal complications? Hypoxia is not very common though. When the mother is having anemia, there is a
Hydroxythalase?
that is fetal anemia. I'm talking about mother is having anemia. As a result, what can happen to the baby? Rarely, if the mother is having anemia, if the mother is having anemia, rarely it can cause IUGR, but it's not very common. IUGR is possible, but not very common. Preterm deliveries can happen. Preterm deliveries. Baby also can be anemic. Yes, true. Not very common. Fetal anemia and fetal IUGR are not common. Preterm delivery is common. But main complication of anemia in pregnancy is the maternal PPH. Okay, maternal PPH is the main concern as far as the anemia is concerned in pregnancy. Okay. What is the commonest type of anemia in pregnancy in Sri Lanka? That is nutritional iron deficiency anemia. It's worldwide, it's iron deficiency anemia. So we will talk about the iron deficiency anemia. To diagnose, say for example, if a patient comes to your clinic with features of anemia, or when you examine the patient looks pale. When you look at the conjunctiva and the tongue, patient looks pale, anemic. So how will you investigate this patient in pregnancy? She's pregnant now. What will you do next? Clinically, in addition, patient looks pale. When the patient pale, right? So what will you do? Yes. If you detect clinically pale, your next step is do a full blood count. By doing a full blood count, you can see the hemoglobin level. You can see the WBC count. You can see the platelet count. Patient may be having isolated anemia, or patient may be having sometimes pancytopenia. Platelet also low, WBC also low. So by doing a full blood count, you can exclude those possibilities. And in a full blood count, though, you can see the severity of anemia. Whether it's what is the hemoglobin level? Whether it's 10, whether it is 9, whether it's 5, 4, you can see the severity. And one of the other things that you can detect with the full blood count, though, red cell indices like MCV, MCH, MCHC. Can you remember about these things? In iron deficiency anemia, what happened to all these parameters? All the parameters will be low. Whereas in thalassemia, your MCV is low, MCH is low, but MCHC is normal. So likewise, you can get various details just by doing a simple full blood count. So if you clinically detect anemia, your next step is full blood count. Then, what's the next investigation done? Next investigation would be blood picture. Blood picture. Blood picture. By doing a blood picture, what are the things that you can see? You can see the morphological appearance of red cells. Whether they are small red cells, hypochromic microcytic, whether they are large red cells, megaloblastic, or macrosomic red cells, or whether they are normal sized red cells, normochromic normocytic anemia. So likewise, you can see the morphology of the red cells by doing a blood picture. Okay. Then, what is the next step now? If the hemoglobin is low, MCV is low, MCH low, MCHC also low, blood picture shows hypochromic microcytic picture, then iron deficiency anemia is likely. What is the diagnostic test for iron deficiency anemia? That is serum ferritin. That is confirmatory of iron deficiency anemia in pregnancy. Okay? Right. This is how you do the investigations. Then, when it comes to the management of iron deficiency anemia, you have three options again. What are those three options? Oral iron, IV iron, Third one, blood transfusion. Oral line, parental line, blood transfusion. So you can get two scenarios. One scenario is, suppose a patient comes at for the booking visit at 12 weeks. 12 weeks, she's come for a booking visit and you have to do the routine in full blood count. When you do the full blood count, hemoglobin is say 8. Hemoglobin is 8. And when you do the investigations, confirm iron deficiency. Hemoglobin is 8. So what will you start with? Are you going for oral iron? Are you going for blood transfusion? So what is the main concern about anemia and pregnancy? PPH. Does this patient having a risk of PPH at the moment? No, she's just in the initial part of pregnancy. So the PPH risk is very remote, isn't it? All right. So in that case, Daru, you have enough time to correct this hemoglobin deficit. So what you can do is, you can start with oral iron. Put the patient on oral iron, and after some time, you can check the control of the hemoglobin level. You can check whether the hemoglobin has picked up with oral iron. What is the response you expect with oral iron? You should get 1 gram per deciliter in 1 week. So that means, suppose today my hemoglobin level is 8. If I start taking oral iron after 1 week, next Thursday, my hemoglobin will be 9. Following that will be 10. Like every week, you will get 1 gram increase. If you do IV iron, what is the response? Same. Why you are giving IV iron instead of oral iron? What's the purpose? Because yes, if you give IV iron, they will go and replace your stores, that is your bone marrow, right? It replace whatever the deficit in the bone marrow and keep them steady compared to oral iron. Otherwise, the response is same. Blood transfusion, what is the response rate? If you give 1 pint, immediately your hemoglobin will be increased by 1 gram. 1 pint, 1 gram. So if you want a fast correction, this is the best. Oral line, parental line, the response is slow and the same. Whereas blood transfusion action is very fast. Right? Very fast. Okay, now my question. 12-weeker coming, confirm iron deficiency anemia, hemoglobin 8. What will you do? Since the postpartum hemorrhage, PPH risk is remote for this patient, you have time. What you do is, the less complicated or least side effects drug, that is oral iron, you start oral iron. After 1 week or 2 weeks time, you recheck the hemoglobin level. If the hemoglobin has increased, okay, you can continue with the oral iron. Suppose you give oral iron, after 2 weeks, you recheck the hemoglobin same, not go down. What can be the possibility? One of the main possibilities, common possibilities, compliance. Even though you ask the patient to take tablets, she has not taken the tablet, she has thrown away the tablet. Why? These hospital tablets, they are causing metallic taste. So when you take oral iron, so most of the patients, they just discard the tablets. Compliance is a problem. So when you check after 2 weeks, if the hemoglobin level is same, most likely the compliance is the problem. What you can do now? I need to do that. What you can do next line of management is you admit the patient and do IV iron. Yes. Then you are sure that this iron has gone into the circulation. So if the compliance is poor, the only best option is IV iron. Okay. So normally the first part of pregnancy and anemia and pregnancy, usually you manage with oral iron. If the compliance is poor, you go for IV iron. Okay. On the other hand, there's another posh girl. So a posh girl, doctor, I'm so difficult in breathing, doctor. Something like patient is really dizzy, having palpitations, tachycardia. First part of pregnancy, say 12 weeks again. Hemoglobin is say 7. Hemoglobin is 7. Patient is symptomatic. Tachycardia, dyspnea, G7 features of impending heart failure. What you can do? In that case, though, you need to have a fast correction of this anemia, otherwise patient can go into heart failure. So if the patient is having features of heart failure or impending heart failure, you might have to consider, even in first part of pregnancy, blood transfusion. Otherwise, almost all the cases in first half of pregnancy, you can manage with oral iron, failing that IV. However, if the patient is having impending heart failure, better to give blood transfusion. Okay, right. That is early part of pregnancy. Suppose there's another patient, say defaulted patient, para 6, right? So unwanted pregnancy, unplanned pregnancy, no proper follow-up. She is coming for a delivery. She is now 40 weeks, for example. She is 40 weeks coming for a delivery, and when you check the hemoglobin level, hemoglobin is 8. What will you do? Yes. Now, this is a patient who is a very high chance of postpartum hemorrhage. So, most of the cases, though, if you're going for a delivery, hemoglobin level target should be at least 10. 10 is the target. So, you need to achieve that target quickly. By giving oral iron, the action comes in male. So you can't wait such a long time. So what you have to do, consider blood transfusion as the first line. Not the oral iron, not the IV iron, blood transfusion is the first line management for that kind of a patient. Okay. Whether the patient is symptomatic or asymptomatic, better to consider blood transfusion as the first line management. Because you need to achieve a target of 10 to minimize the risk of postpartum hemorrhage and their complications. So consider blood transfusion as the first one. Okay. Whether the patient is symptomatic or not, you have to start blood transfusion as the first line in case of anemia detected towards delivery. Is that clear, Darwani? So anemia, SBS, you can get 2 SBS actually. Anemic patient, early pregnancy. Usually managed with oral, IV, and if the patient is really severely symptomatic, consider blood transfusion. Anemia detected towards the latter half or towards delivery, closer to delivery, patient may not be symptomatic, patient is okay. Suppose if you take an estate worker, right? Her hemoglobin may be 6. However, she's doing everything by her own. She's not symptomatic at all, but still, if you are going for a delivery, you have to achieve the target at least around 10, safe. So then you have to consider blood transfusion. Okay, right. What about the anaphylaxis risks at the time of delivery while having blood transfusion? Yes, always, Daruni, when you consider an option, there is a side, there is the risk associated with that option. Say, for example, now we all know when you are walking along the road, you can come across something, you can meet with an accident and you can die. But still, you have to use that pathway, isn't it? If that is the only road that we have to use, you have to go, right? So the pregnancy also the same, medicine also the same. Medicine, always there's a risk and benefit. You have to weigh. Okay? Risk of anaphylaxis is there with blood transfusion, that is true, and there's a risk of infection with blood transfusion. They all are true, but the life is much more important than anything else. If there is anaphylaxis, you can manage, but if patient develop severe PPH and if a patient have the cardiac arrest, then that is the end of the story. Okay, right? That is also like the vaccine these days, vaccine, Pfizer or something, right? You all know that Pfizer vaccine or any other vaccine can cause problems in later. But if you are not getting the vaccine now, you can develop the COVID pneumonia next month and can die. ERPM exam can die. So better to get to your vaccine. Always there's a risk and benefit that you have to assess. Okay, right. All right, Daruni. So I'm sorry I took some additional time from you all. So today we have discussed 3 important medical disorders in pregnancy: preeclampsia, then diabetes in pregnancy, and anemia in pregnancy. I hope I was able to do something for you all, right? So next week also, coming week also, I'll try to do a session like this, malignancies. So if you are interested, you can join Daru. And all the best for your exam, and get ready and keep in touch. If you all have any queries, any questions, you're welcome at any time. Okay, so have a good sleep today and start studying tomorrow onwards. Thank you for joining.
Excuse me, sir.
Yes, Daru.
Sir, in diabetes in pregnancy,
Can't hear Kollu. Kollu, yes.
Can you hear me, sir?
Yes, now I can hear you. Yeah.
So in diabetes in pregnancy, in the first trimester, is there a place for HbA1c?
Yes. HbA1c mainly for the prediction of complications. Okay. All chronic diabetic patients, before they have a pregnancy, before they have the conception, they have to get down to HbA1c levels. So HbA1c should be below 6.1, or some say 6.5, whatever it is, below that level. Okay. So if you have HbA1c of this much, you will have a safe pregnancy and the complications of diabetes will be minimal. Whereas your HbA1c level is high, you can say, look, it's not good to have a pregnancy. You may have all these complications in near future. If the HbA1c level is more than 10, like, it's almost like contraindicated for pregnancy because of the complications. So likewise, you can predict complications by doing HbA1c. Okay. In the first trimester also, you can do HbA1c levels, but best thing is, for the prediction of complications, you have to do pre-pregnancy HbA1c. But HbA1c level can be done in the first trimester as well. But latter half of pregnancy, HbA1c level is unreliable. Remember. So you can't do HbA1c at 30 weeks, 35 weeks, 36 weeks, something like that. It's not reliable. It is reliable only in the first trimester and pre-pregnancy time, mainly to predict the outcome. Okay, HbA1c level is to predict the outcome of pregnancy in chronic diabetic patients. Okay.
Thank you, sir.
All right. So keep in touch, Daruni. If you all have any queries, you are welcome. And thank you very much again for joining today.